Thank you very much for the introduction. And it's always a pleasure to be at this conference. So what we'll try to do is first give a little bit of an introduction on what we see as kind of how the propionic heart presents itself. And we will try to incorporate some of our research findings that we could do thanks to the Propionic Acidemia Foundation grant that actually supported Carla. She will speak later on for 1 year. And so, okay. So as I said, this was supported. What we've heard up to now today is especially about the metabolic aspects of propionic acidemia. But when you really start to look at some of the clinical problems, is like many of the patients in the end, they have problems with the heart, and you see both either heart failure, where the heart doesn't pump well enough, and then they might kind of pass away because of that. And on the other hand, we have sudden cardiac death, as we say, which is mainly caused by arrhythmias, so that you have sudden arrhythmias where the heart stops functioning properly. And so these are two aspects that have been studied in the past, that we are studying, and that we are trying to get a little bit more in-depth insight in. And I want to start with showing you a couple of aspects about normal hearts and about what is important when we look at a heart. Because one of the things that you will see is like a propionic heart is very different from any other heart and has to be managed as a propionic heart. It's not a heart failure heart, it's not a sudden cardiac death heart, it's a very, very typical propionic heart. So when we look at how the heart functions, as you can see here, this is a typical echo of a normal person, and what you can see is like when we look at the heart, well, first of all, the heart has 4 chambers. But what we do is we mostly concentrate on what we call the left chamber, the left ventricle. And that's actually the chamber that when it contracts, it pumps around the blood towards your body, towards the muscles, towards the organs. So that's in some ways like the biggest part, and in many conditions also the most important part of the heart. And what you clearly see is like, even when you just look at the shape, it's like a normal left heart is like very elliptical. It's like an elongated heart. And as you see, like it contracts in different ways. So what you see is like, when we look at how this contracts, you see that here, this valve is moving down. And at the same time, you also have this, that the diameter changes. So you see that there's different components that help in order to make sure that with every heartbeat, as much blood as possible is being pumped out towards the body. And there's different ways that we can look at this also. So there's ways that we can measure what are these different components of contraction. And what is most important is that we have to study this for kind of specific changes that we expect. When you go to your cardiologist, and when you heard 2 talks in the past, a lot of people are talking about ejection fraction and problems with ejection fraction. Now, the ejection fraction is the amount of blood, percentage-wise, that is being ejected out of this chamber with every heartbeat. So if you have an ejection fraction of 50%, that means that with every heartbeat, 50% of the blood inside that chamber is being pumped out towards your body. If your ejection fraction is 30%, very, very much reduced, only 30% with every heartbeat is being pumped out, which means that, of course, you need a lot more heartbeats in order to get the blood flowing, in simple kind of terms. So ejection fraction tells you something about the overall functioning of the heart, but the problem is that while ejection fraction is quite good in many heart failure patients, what we will see is ejection fraction is near to useless in PA patients. We have to look at it differently, but we'll come back to that in a minute. So when we talk about the changes, it's like typically you would hear that a PA patient gets a dilated cardiomyopathy. Cardiomyopathy means a myopathy that is something wrong with the muscle, cardio, of the heart. So cardiomyopathy is a disease of the muscle of the heart, and dilated means it became bigger. So it just dilated. So you see that a dilated cardiomyopathy, as compared to normal, is a larger heart, and it became larger because of a problem with the heart muscle. It's a normal reaction of the heart when something is going wrong. It kind of tries to become bigger, and you can understand, it's like if with every heartbeat it needs to pump out a certain volume, of course with a bigger heart, you can do with less effort, in some ways, pump out enough blood. It's like that's more or less the reason why it is. But there are a couple of problems when it really, really gets big. So while it helps in order to kind of do the ejection, when your heart becomes very, very big, it's actually being stressed more. You can see it already. I mean, if you blow up a balloon, the more you blow up a balloon, the harder the balloon becomes. And it's a little bit the same with the heart. If the heart becomes too big, actually it gets into problems because of the fact that it's too big. So a dilation of the heart is a natural compensation of a problem with the heart, but it will cause more problems on the longer term. So that's a little bit what's going on. Now, one of the other things that you will see that becomes important, and that is something that we see with dilatation very often, is that the heart also, instead of nicely elongated, like an ellipsoid kind of shape, it becomes more spherical, it becomes more round. And you can see when you start thinking about it, like there are good reasons why it becomes. Again, the same, if you blow up a balloon, the more you blow it up, the more spherical it will become. It's like a way to kind of try to deal with being so big. Now, the problem is, if you're spherical, while that might be a good compensation in some conditions, actually a spherical heart is less efficient. So when you look at why we actually have these elongated hearts, is because that's actually the best shape in order for the heart to pump most efficiently for a very long time. Every time it becomes more spherical, it will actually be an adaptation to something that went wrong, but it is less efficient. So if at some point you have a more spherical heart than somebody else, you have a higher risk of getting into cardiac problems or not. So what we will see is that this sphericity, so becoming a spherical heart, while we know that with dilated hearts they become spherical, it's not so much known that also smaller hearts with a normal size can actually also become more spherical than normal. And this is a thing that we will show, is this is something that's happening in PA patients, and that, as I will show you later on, is even happening in carriers, so that you have a change in the shape of the heart. Of course, if you at the same time have a spherical heart and a very dilated heart, you have a heart which is extremely vulnerable to problems. And that's what is actually happening. We come back to that in a minute. Let's briefly, before I go into some of the measurements that we got in our study, look a little bit at what people have been talking about in the PA cardiomyopathy. And one of the things is that has been suggested that there's a long QT syndrome. Now, long QT syndrome is a very, very specific cardiac disease which is related to a genetic mutation of ion channels. PA mutations have nothing to do with this mutation, and almost all PA patients do not have this mutation that is linked to long QT syndrome. Although in the plain population we see that there's a few, so it's very, very important that you know your whole genome. Just knowing whether you're a carrier or having homozygous for PA is not enough. You need to know the rest of your genome, because that's actually very, very important for your management. But overall, what people have shown is that the QT, so that's actually when you look at an ECG, we come back to that, Carla will show exactly how this is measured. So that has to do something actually with the time that your heart needs in order to do the ejection. So I told you before that with every heartbeat, you eject 50 to 60% normally. The same is that with every heartbeat, of course, you have a time of ejection and a time that blood comes in again in order to prepare for the next ejection. And normally the time of ejection is about 1/3 of your whole cardiac cycle. So with every heartbeat, in between two heartbeats, about 1/3 of the time is used in order to do the ejection, and 2/3 roughly is being used in order to get the blood in again for the next heartbeat. If you have prolonged QT, that means that you actually have a much longer ejection time. And that can lead to problems. In long QT syndrome, this is associated with arrhythmias. What we see in the PA is that we see that there are prolongations, not all patients have prolongations, and what's also very important, and that has also been shown before, is that actually there's quite a lot of variability in an individual. So you don't always have a long QT. Regularly it's below a threshold, sometimes it's above. So actually it's very different from the traditional long QT syndrome. Now what is causing this long QT, there's still discussions about it. So it's clearly not long QT syndrome as being used in other patients, but it might be metabolic. So it has something to do with the activation of the heart. The conduction system of the heart, because what you have to keep in mind, in order for the heart to beat every time, there's like a little electrical pulse that you also see on the ECG, that's why we take ECGs, and this little electrical pulse has to be propagated throughout the heart, and this seems to be changing in PA. We don't know why. Is it a metabolic component? Is it a structural component? Does it have to do with the fact that the heart is rounder and bigger? These are still open questions in some ways. Now, one of the things also that people have been saying, it might be related, especially this QT, might be related to the cardiac size itself. We will show later on that it is a little bit related, so there is like controversial information there. But one of the things that is clear also is that there are functional abnormalities. There are PA patients that indeed have a reduced ejection fraction, but these are the ones that are really failing. Ejection fraction in itself is not the best way to look at them. There's other ways, as we said before, you can look at strain, some of the things that I'll show you later on. Timings within the cardiac cycle might also be quite important. Now there's one interesting paper also that's a little bit hidden in the literature, is like there's one paper of a Dutch group, and what they did is they looked at a population of heart failure patients. So they looked at patients with dilated cardiomyopathy and heart failure in their general population, in their clinic, and then did genetic kind of screening of these. And what they actually found is that they identified 2 patients which were heterozygous for propionic acidemia, and that actually had a dilated cardiomyopathy with heart failure. So there might be an association, and I come back to that in a minute also. So we really also have to look at heterozygous and not only at the homozygous. So the study that was supported by the Propionic Acidemia Foundation, and that's a study that we already started before, but we could roll out a little bit bigger thanks to this grant, where we started to look at a more comprehensive cardiac assessment of PA patients, but not only of PA patients, and that's also why we ask you if you're being kind of echoed and get an ECG, that we want to see a whole family, because we want to compare the homozygous PA, so the ones that really have PA, with the carriers, and ideally with normals, and we prefer, of course, normals of the same family. Because we know that in cardiac conditions, things like lifestyle, diet, and things like that, they influence the heart. So preferably, in order to have a kind of clear comparison, we want to look at the whole family, the carriers, the homozygous, and the non-carriers. And this is what we started to do. So at this moment, we have been looking at about 180 patients. From all these patients, we don't have the full data yet. We will present some data that we have now. But one of the things that you immediately see is that what you see is that we have predominantly, of course, the PA patients. We have predominantly homozygous, and we have very, very little controls. Normally, you expect genetically 25%, 50%, 25%, and we're not there yet. So this is another request for all of you. Please bring your non-carrier siblings or family members in order to be scanned, because we really need them for comparison. And the other thing also, when you see it, so we predominantly have children to be scanned, and we have much less, especially for the controls also, in the older population. And I think starting to look at older carriers and PA patients is really, really important, because that, of course, determines what is going to be the cardiac outcome, and we really need to understand what's happening, because these are obviously the ones that get into trouble potentially. I'm not going to go in detail, but I want to show you some of the preliminary results. We're still analyzing the data, so it's just a little bit preliminary. As I said before, we have young population with a balanced gender. There is obviously a difference in BMI, so where we see that the PA patients are obviously much, much smaller or lower weight than the others. And that's the main thing that is important. Now, one thing that you can also see is like when we look at the plain population specifically, we have to keep in mind that there's also other mutations that can play a role, even in the normal or in the carriers, and this is some of the things that we start to see. Just to give you an overview of some of the information, I'll walk you briefly through this. One of the things that you see immediately is that the heart rates of the PA patients here are in red, is higher than normal. But what you also see is that the carriers, so the heterozygous, the one with just one copy of the gene, that they are actually also different from the non-carriers. Not only in heart rate, but also when we look at the QTc, for example, we see indeed that the homozygous are prolonged, but what we also see is that there actually seems to be a prolongation, or at least a shift towards longer QTs in the carriers. Similarly, for alterations, like T-wave alterations, so these are changes in the ECG. Mechanical dispersion, that's important because that is potentially in adult cardiology kind of suggested as a measure or like a risk for arrhythmias. We'll see that that's also changed, but that is very, very preliminary data. What you see here is ejection fraction is absolutely non-informative. So ejection fraction, only when you have like a dilated cardiomyopathy with really a lot of symptoms, obviously your ejection fraction is down. But using ejection fraction for management or for kind of diagnostic reasons or whatever is absolutely not useful. That's very, very important. What is useful, though, is sizes of the heart. What we see is that the propionic hearts are bigger than normal, but similarly, the carrier hearts are also bigger. So all of you that are carriers, you have bigger hearts than the normal population or than your siblings, which are non-carriers. When we then look at the sphericity, what I told you before is you get a more rounded heart. If you have a dilated cardiomyopathy, by definition, you get a more rounded heart. Everybody does. But there's actually, as I said, also smaller hearts that are more rounded. And that's what we see, actually, is that both the homozygous and the heterozygous have rounder hearts. Now, as I said before, a rounder heart is actually a risk factor to much more easily get cardiac diseases later on. We see that, for example, also at children from the general population without genes that are born with very, very low birth weight, what we see is that they actually also have rounder hearts. And typically what you see is that they have less exercise tolerance than somebody else. So I can imagine that many of you that are carriers, you have more spherical hearts, and maybe you can exercise a little bit less than many of your friends that are absolutely non-carriers. So this is something that is currently not known a lot, and what the influence of that is not known neither. It's not going to lead to PA. You're never going to get PA when you're just a carrier, but you might have more problems with your heart than somebody that's a non-carrier. Now then we try to look at all these parameters that are changing. Is this changing over time? Is this age dependent? Does this get worse over time? And then you start to see that actually there's almost nothing that changes over time. When we look in the children population, what we see is that there's a very weak correlation that the QTc would prolong over time. But sphericity is not changing, volume is not changing, and also if we look at the whole population, but again, it's extremely weak. It might be that you get a bigger heart over time when you have propionic acidemia. But what is clear from this is that the age relation is very, very weak. That implies that you're actually born with this. So that implies that actually highly likely the cardiac phenotype, as we say, so what your heart looks like, is actually determined while you're still in the womb. So that's while you're growing, then propionic acidemia becomes already important. So this is also something that we have to investigate, because it might be that dietary kind of measures of pregnant mothers might help in order to improve the cardiac phenotype. We don't know that, but there's a clear suggestion that this is something that happens while you're developing in the womb. When we look at the relation between the different parameters, then we see also that there's kind of no real relation. One thing is that the bigger your heart, the more spherical, but as I said before, the smaller hearts are also already much more spherical than the normal population, from the homozygous as well as from the carriers. And we don't see a clear correlation of QTc and size, so these are not really directly related. Just also out of interest, we looked at one PA patients that we've been following over time, and we looked at several of the parameters. Where you see is that the blue is the BMP. So BMP is a blood marker which is related to severity of heart failure. The higher your BMP, the more your heart is starting to fail. So it's an important way in order to try to manage it, but it's a blood measurement that is not that easy to do. Then the QTc, and here in green, although not that clear on the projector, is the size. And what you see here is that although it's all over the place, which is one thing that is also very important, is like PA patients don't have a stable heart. They have very, very variable hearts in size, in QTc, and what's going on. So it's not that you have a PA heart and it gets worse over time. No, it gets worse, or it can change almost from day to day. And one of the things that we also see is if it's bad, everything goes bad. And if you start treatment, here this patient at the moment that it was in the worst condition really had symptoms of heart failure, we increased the treatment, and you see that all the parameters actually go down. And so the parameters of the heart, the PA heart, is something like you're born with a heart which is very prone to problems, and you can easily get into problems, but treatment can get you out of this also. So it's a very fine balance in order to keep you out of real problems with the heart. So just to kind of in some way summarize, I don't know why this is not. Yeah. Sorry, this should be beating also, but it's kind of starting. So you see here, you see two different hearts, a normal heart, a propionic heart. As I said before, propionic hearts are very, very specific. They are much more rounded. In the beginning, they're not even much bigger, so actually this heart is a little bit smaller, but they're very rounded. So now, for example, also, when a patient comes to Dr. Chowdhury's echo lab, she can immediately say, okay, this is a propionic heart, just because of the very, very typical shape. And as we said before, even in the youngest kids, we see that. So you're born with that heart. Now, as I said before, what is important is that this spherical heart makes you more prone to problems. So you really have to try to manage this. Now, there's a couple of other things that we have been noticed and that we have to investigate further that we haven't finalized yet, is that what we see is that when we look at how the heart is really contracting, some of the things we see is that, of course, if the patient goes into heart failure, we see there's less contraction. So what we see is that predominantly the longitudinal contraction, which is actually how your valve moves downwards, that component specifically is being changed. But what is also here, and I'm not going to go in details, but there are suggestions that there are problems with the activation of the heart, with how the heart is electrically activated. There seems to be some delay. So it's highly likely, like when you look at your heart, the electricity of your heart actually goes through specific cables. You have like little cables all over your heart, at the inside of your heart, that makes that once on your ECG you see this electrical pulse immediately starts the contraction of the whole heart at the same time. In PA, it seems to be that this doesn't happen at the same time. And there's some evidence of it. And this is not known yet, and this might be because we know patients that have this very, very severely, it's what we call left bundle branch block patients, they're very prone for arrhythmias. And the PA heart is towards this. It's not as bad of what we say, these left bundle branch block patients, but it goes into that direction. So this would potentially be one of the sources of lethal arrhythmias. The other thing that we also see is that not all parts of the heart contract the same. A normal heart, all the parts of the heart contract as much as the others. In the PA, what we think is that the basal part is not contracting as much. And that mostly has to do with accumulation of kind of metabolites within the tissue. And so this is also something still to investigate. And some other thing, again, we don't have definitive data, but what we see also is that the timing is like when the heart starts to contract with regard to the electrical pulse, and how long it can contract in order to do the ejection, that has been changed also, which is probably related, again, to this electrical kind of conduction system. So overall, what you see is that predominantly the propionic heart at birth is a disadvantaged heart. Even the carrier heart is a disadvantaged heart. It's more rounded, so it's more stressed in the walls, and it's less efficient, and especially the propionic heart has problems with pressure loading. If you have a dilated heart, which has problems, if then you suddenly increase your pressure, and that can be by suddenly starting running, for example, because there are some, I don't know if it's in any of your families, we have patients that started running in order to catch a bus, for example, or started running in order to capture a horse and things like that, and they have problems with arrhythmias. That's because your heart is not prepared for these sudden changes. No sudden changes, especially in blood pressure, or sudden changes in the heart rate can lead to, all these can lead to problems. So the heart failure is likely with problems with this kind of the size, the shape, the way that the heart is activated, potentially some depositions within the tissue. We still need evidence for that. So that leads to heart failure at some point. And the arrhythmias is like, as we said before, it's not a traditional long QT syndrome, but both structurally the heart is more prone to arrhythmias. And the other thing is this thing with conduction system, we think something is wrong. But the most important is that we see, and we have some evidence from other things there also, is that a heart like this, if you suddenly increase the pressure to this heart, then it starts to skip beats and potentially starts to get into arrhythmias. So the most important is that there should not be sudden changes in the blood pressure within that heart. So to conclude a little bit, so it's clear that the propionic heart starts from birth. We almost show, well, actually starts before birth. So that's a thing that we have to look into also. So also some of the therapies ideally should be done before birth as much as possible. There are very much more globular hearts that have problems with the contraction and the ejection. There are problems with the conduction that we still don't understand fully, that we see some reflections in the ECG, but we mainly see reflections in how the heart exactly is contracting. But what we do know is that the left ventricle is prone to failure because of the shape and these contractions. It's prone to arrhythmias, likely because of these contraction patterns and the conduction system, and is absolutely not adapted for pressure loading. So when you have to manage a propionic heart, it's very important that it's done specifically, and that means that the loading, so the pressure changes have to be managed. Lifestyle also is like they shouldn't do sudden exercises. Nothing should be done suddenly in these hearts because that relates to problems. Heart rate control is very, very important. A high heart rate, again, can lead to problems, but on the other hand, a very low heart rate is also problematic. We see in some older patients that they actually have too low a heart rate, and the only way that with a low heart rate your heart can work properly is becoming bigger. And as we said before, this becoming bigger is a big problem. So there is a sweet spot in the heart rate, and also what needs to be done is that sudden changes in heart rate and pressures cannot be happening, and that is what we try to do with things like beta blockers, for example. So there are drugs that can control this. But what is very important also is propionic heart is specific. If you go to a cardiologist, make sure the cardiologist understands the propionic heart, because it should not be treated as long QT syndrome, and in general should not be treated as a pure dilated cardiomyopathy, because some of the drugs that they give for these conditions are not well tolerated or not ideal for the propionic heart and can actually even make it worse if you don't take care. Okay, that's more or less what I wanted to say. I don't know if there's any questions at this point. No, you can say something later or now if you want.
So before Carla starts, just a couple of comments. People ask, which is a better beta blocker, atenolol or nadolol? Which beta blocker should be used? So there was a time we did not use beta blockers on these patients, but we use them now because we don't like these sudden increases in heart rate. So the beta blocker is given, at least the way I understand it, is to prevent that sudden increase in heart rate. So you got to keep that controlled. The second thing is that the beta blocker, apart from controlling the heart rate, also decrease the heart function. So there are negative inotropes, as we say, that they can decrease the function. So if you have a patient who has propionic acidemia and already the heart is dilated and you see that the function isn't great, then to add a medication that will further decrease the function can be challenging, Now, we obviously have talked a lot about QT in this talk. Now, QT is an interval that talks about the length of times electricity takes to depolarize and repolarize the heart. And there have been many studies that have shown that if the QT interval goes over 500, you are at risk for sudden death. Why does that happen? Because if the QT is really long, the new beat that's coming in doesn't have a gatekeeper because there is all this dispersion of electricity and you can go into abnormal rhythm. So we typically don't see a QT over 500 in patients with propionic acidemia. Now, there are a couple of patients that do have a QT over 500. If you do have a QT over 500, then I do think it's reasonable to put that patient on nadolol. Now, just to back up a little bit, why do we pick nadolol for long QT and not for, why are we saying no for propionic? So in long QT patients who have the genetic long QT, that means the ion channels. What are ion channels? Ion channels are like tunnels within the heart cell through which potassium goes out. So if that tunnel is small and the potassium is taking a long time to go out, you get what is called as genetic long QT, which is what we don't think is the mechanism of QT in a patient with propionic acidemia. But QT patients have sudden death. Why do QT patients have sudden death? Because it is a fright, flight, fight response that causes sudden death. And the reason we give beta blockers is we want to cut that response. So we want to do something that will not activate the sympathetic system, the fright, flight, fight system. Right? So we want to give the strongest beta blocker possible for that, and that's nadolol. And typically, congenital long QT patients will have a normal cardiac function. So those hearts can handle these strong beta blockers because their heart function is normal, so the heart function does not go down in those patients. But now we have patients who do not have normal cardiac function. We still want to block their heart rate. Now, typically, when we look at a heart failure patient, there's another beta blocker we use, which is called as carvedilol, because we don't want to, again, use a strong beta blocker in a heart failure patient because their heart doesn't function right. But the problem with carvedilol is that it does not block your heart rate enough. So you can still get those surges in high heart rate. So we have to find a sweet spot, and we think, at least I think many times, atenolol or metoprolol works well to prevent that sudden increase in heart rate and does not have such a negative inotropic effect on the heart function. But if you have a patient who has a very high long QT, over 500, then I think everybody would say it's reasonable to put them on nadolol, because even if we don't find a mutation that's causing long QT, who is to say they don't have a mutation for long QT that we just didn't know about, So typically for what these patients, the other thing to remember is the normal for blood pressure is a different number. So a blood pressure of 120, 140 is high for these patients because the heart is already rounded. We want this heart to put in less effort, less energy to eject that blood out. So that's why a lot of these patients, I put on a medication called losartan, which decreases the blood pressure. We try to keep their top number of the blood pressure between 90 and 100, 90, 100, 110 in that range, and keep the heart rate around, you should not get a maximum heart rate over 140 or 150, even with extreme exercise. So you want to beta blockade them, you want to keep the blood pressure low, and of course, lifestyle changes. So I have a couple of patients who have propionic acidemia, and they are these young adolescent kids who feel fine otherwise and want to keep up with their peers. They want to do everything that the rest of their group is doing. But sometimes we have to have them slow down. So what I would typically say, if you can reach the top shelf of a cabinet, try to go to the shelf below that, that's what you should try to do. Not go all out, but just try to slow down a little bit, So those are the medications. Now, we've had a couple of patients who've required heart transplant. Then they go into full-fledged heart failure, and then we are using drugs like Entresto and all these other medications. And those patients are the ones we start seeing the brain net uretic peptide, the BNP level, going up. The BNP level typically will not go up in these patients. It runs just above upper limits of normal. But once your BNP level starts climbing, you really have to start connecting with the transplant center, because we don't know at what point this heart's going to need transplant, So important to make sure that you drink enough water, keep your blood pressure low, do not put on too much weight, and do activity as you are allowed, as you can do. Don't push yourself beyond your limits, So that's sort of what is the management that we follow in our practice for these patients. And again, the BNP level goes up and down. The kid gets in with the propionic acidemia crisis, Those kids get very tachycardic. I mean, I don't know if you've seen that. The heart rates go so high. The EKGs then starts showing some QT abnormalities. And then usually as the crisis comes back, these children get better, and I usually follow their BNP levels at that time, So I think as time goes by, I think every time I see patients, I get better at understanding some of these things. But do we have like a cure? No, we don't. And as you've heard from previous speakers, we try to do heart and liver transplant many times on these patients. We have at least 5 of those patients who had a heart and liver done at Cleveland Clinic, and there are a couple of other patients who we hear of anecdotally who've had heart and liver, and and the liver transplant is done because of the metabolic disorder. I think there is one patient who didn't have the liver transplanted, and that patient is a few decades out, but we are seeing some changes in the heart, So before Carla goes on, if anybody has questions.
Maybe in the meantime, still a small comment is that we see is that the cardiac crisis is not necessarily coinciding with the metabolic crisis.
Yes, that's the other.
Because the cardiac crisis is mostly caused by changes in loading, changes in pressure. So things like infections and things like that could cause a cardiac crisis independent of metabolic crisis. So that's very, very important to know also.
But sometimes, I see a patient in the office. I saw this kid who was so this child presented to me as a newborn with tachycardia. We didn't even think of propionic acidemia in this patient, and I didn't think much of it. 3 years later, he presents with a crisis, actually, and then we make the diagnosis on this child. 2 years later, when he's 5, he again presents with tachycardia, and the family tells you there's nothing wrong with the kid. The kid's completely fine. His heart rate is high. The echo looks really terrible. And how does the echo look terrible? When the heart rate goes up, I see that dyssynchrony that Bart had shown on the echo really gets exaggerated, and the child just doesn't feel great. BNP goes up a little bit. You give them a beta blocker, bring down their heart rate. It's almost like the heart calms down and starts functioning much better, So there can be up and down in these hearts. There is some reversibility with changing the loading conditions that we can see in these hearts, Sorry, you had a question,
That's fascinating. I was just going to ask you to comment on a few things. We've studied many patients at NIH, more than 60. Everybody gets echo, EKG, Holter, and many of our patients get cardiac MRI. Mm-hmm. And we have many patients that are normal.
So
and I'm just wondering, I'd be curious at the first diagnosis if there's a suggestion of a congenital phenomenon, which, who knows, right? We haven't checked everybody. There's that. Then the mice don't have this. Now, yeah, mice versus humans, you can have that discussion. But in mice, even some mice that have mutations that would predispose. So I'm wondering when you do this, maybe this will come up later, are you mutation stratifying? That's important because patients have different mutations. Some people have stop codons, indels, missense mutations. So that could affect anything you see anywhere, the nature of the mutation. And as you pointed out, whether or not there's second hits in the genome. But we're not seeing, at least, I'll go back, and I'm not a cardiologist, I'm not qualified to look at echoes, but we have some patients that are totally normal. We keep scanning them over and over and over and over again, and we don't see anything.
So I would say beauty lies in the eyes of the beholder, okay?
Yeah.
So I've been in
Including
that.
cardiac MRIs.
Yes, so I have
That
been
have been
through
reviewed
this.
by teams of experts. That's
know.
all they do.
I totally hear you, and I can tell you about echoes too. So these echoes are read as normal because they have normal numbers. So they don't get the z-score that's above normal, okay? But if you look at their shapes really carefully, their basal area is dilated, number 2, and as these patients progress, these hearts, if you look at their aortic outflows and you look at their isovolumic contraction times, they start changing, So like this one patient I was telling you, his ratio of your isovolumic contraction time of the left ventricular outflow and the right should be the same. But as these hearts become dilating or the basal area increases in size, that ratio changes. So it'll be 93 for aorta and 53 for the PA. We typically don't measure that on our echo. As far as MRI is concerned, the same thing. The ejection fraction on the MRI is normal, or it'll be low normal. It'll come out between 52 and 58 or something like that. So it's not read abnormal. There's no gadolinium enhancement in these patients. Yes, I'm saying there is no gadolinium enhancement. Even if you do a GAD MRI, there is no gadolinium enhancement till you get to the burnout cardiomyopathy, which is like your final pathway of a dilated cardiomyopathy, your BNP is climbing. Then we may see. The only other thing we have seen is a little bit of what is called as a change in T2, which is the relaxation time, which goes along. So the report would just say mildly prolonged relaxation time, which goes along with some kind of a deposition. But again, that we see that towards the terminal end of the disease. We don't see it in the earlier part of that disease. And so we've done a lot of MRIs. We have MRIs on a lot of these patients, and they do not come out abnormal. And the MRI, of course, is a cost to the community, so we don't routinely do them unless there is an issue. Now, the comment about the genetics, since we are studying the Amish mutation, the PCCB homozygous, it's the same mutation. All are PCCBs, all of them, and
90%,
we have more than 90%. I think we have 2 patients. One is a PCCA, and one is a double heterozygote for PCCA and PCCB. But otherwise, double het, PCC, but most, I would say, are just the Amish PCCB mutations. So we are not looking at that stratifying the mutation, but yes, we are doing as much as we are able to do. I mean, again, we are limited in our data for genetics too. So we do like the commercially available in vitro panel, and we don't ignore the VUSs that are there. So some of these patients will have a MYBPC3, MYBPC3 cardiomyopathy gene. Some have desmoplakin gene with them. Some have a VUS for TTN2. Some will have some other gene. So we are looking at that part, but majority, or I would say they all have the same PCCB mutation. So that is the thing. But I would tell you that even the mice, I would say that when I had looked at those echoes many years ago with your team, I thought those echoes were not completely normal to my eyes.
Yeah.
Some very old mice that were stressed with high protein for almost 1 year of age, only then developed.
No, then they've developed changes in ejection fraction. So it's a little bit what she said before. I mean, I'm quantifying hearts predominantly of adults for more than 30 years based on imaging, from an engineering point of view, from a cardiological point of view. And as you say, it's like echoes and MRs in non-heart failure patients, non-symptomatic heart failure patients, have normal values according to the guidelines. But all of them, as I said before, they're spherical. Nobody measures sphericity of hearts in normal clinical studies. So one of the things, our team has been doing that in other conditions. We haven't done it in PA yet because we didn't have enough MRIs, but typically we would do shape analysis, statistical shape analysis. So in your population, I would suggest to contact a team that can do statistical shape analysis, and I can guarantee you that if you compare it to normal, it will be different. The other thing is when you look at ejection fraction, so when you look at function, so as I said before, traditionally they use ejection fraction. Now people start to use what is called global longitudinal strain, and that changes earlier also in the PA patient. So that would already be a little bit more sensitive. But what is most important is what I said before, is this kind of disparity and like non-homogeneity, dysynchrony type of contraction. And that is only something that people have been doing in heart failure patients with either with either left bundle branch block or right bundle branch block. There we have techniques in order to look at that. But again, normal cardiologists don't do that. Researchers in PA also don't do that analysis. But when you do that analysis, you see that it's very abnormal. So the problem is that echoes and MRs are being reported as normal while they abnormal for things that you're not used to look at.
So that is like, I have patients who get to community hospital and there are different tertiary care centers reading those echoes. And they're read as normal. Then Holmes will call me and say, Devyani, can you re-look at that echo? They will all be read as normal, And I think this septal movement that we see, you really have to look for it, Because the heart, overall, the numbers, you will not meet any Z-score criteria for septal thickness, for LV volume, ejection fraction. So they will, and even the strain, initially the global longitudinal strain is normal. It's a little bit of your basal strain that changes, And just the shape of the heart, the basal area is a little bit dilated,
Hi, I'm Antonetta. My question is, if we do see early changes or abnormalities, is there a change in management?
So the
Should I be
management,
concerned?
as I had mentioned to you, is I usually put these patients on afterload reducing drugs, and I also put them on some kind of a beta blocker to control their heart rate. I do heart monitoring for them. And especially a girl who's 25 years old, there is a lot of conversation about pregnancy, because it is an extremely important thing to understand. Can she survive a pregnancy? She probably will survive a pregnancy. The baby will survive. But what I tell them is if it's really that important to them, they can, but they have to be monitored. And number two, that do not have pregnancies very close by. Let your heart recover, at least give 3 to 4 years, not like every 18 months get pregnant. That's not a good thing for the heart. Heart rate would be really important to look at. I think it's a vital sign that is often not really given that attention to.
What was the first medication that you...
Losartan, which is an
losartan,
afterload reducing agent.
Yeah.
Of course, people shouldn't get pregnant on that, so we have to look at what they can get pregnant on and which beta blocker they can get pregnant on. So it's a little bit of work to get a propionic patient through a pregnancy. I mean, there are anecdotal stories. There is a lady who lives in the community who has had multiple pregnancies and is homozygous, but her body and her heart has taken a hit for it, So that those are all things to remember. Now, one other thing about heart rate I want to mention, you have to be really very meticulous and follow these patients closely because as they get older, so I have seen patients who are in their 40s or 50s, they get bradycardic. So you cannot have them on beta blockers at that time. And there was one patient I remember in the last year that we spoke to a cardiologist and put a pacemaker defibrillator in that patient. So bradycardia is something that does happen to these patients. I'm not 100% sure whether it's the chicken or the egg, is the bradycardia makes the heart dilated or the heart is more dilated because of the bradycardia and it's a conduction system problem. But if you look at the older homozygous propionic patients, their heart rate is low. So I really do think there is some conduction system issue that does occur in these patients.
Do you look at carriers also for cardiac?
So I think I'm going to not take away Carla's thunder. She's going to talk about the carriers, so we can talk a little bit about what she has found in the carriers. So.
Okay, so good afternoon. I'm Carla, and I'm here to present the second part of the results. So in this presentation, I will be going over the second part of the first objective, and then we are going to look at the phenotyping using machine learning that we have done. So first of all, before diving into the data, thanks to these Propionic Acidemia days that we are doing here, and thanks to the group of Cardiology Care for Children, we have been able to enroll about 200 patients, for which all of them we got echocardiography, we got ECG, and we also got demographics data. But As you know, these Propionic Acidemia days are done here at the US, and all the data acquisition is done here. But we are working in Barcelona, the analysis is done there. And as you can imagine, it's not feasible to do a big analysis if we need to take a flight from the US to Barcelona each time that we get new patients enrolled. So that's why in our group, we have been also working towards the automatization of this data transfer, but also working on different tools that allows us to analyze all this data, all of this cloud-based, so that we can get into that data automatically. So our data flow is that we start with a data lake that is where we get all the data acquisition and everything is unstructured. And then we have some orchestrator that allows us to anonymize all the information and get a proper data warehouse that contains the data properly structured that can then be used in the different tools. So in this presentation, I will be also presenting the tools that we have developed in our team. The first one is the image analysis platform, which is a cloud-based platform that allows us to analyze echocardiography data, but not also cardiography, imaging data. We are also working to implement MRI. So the data flow is that we get an echocardiography here, and then it is sent through Orthang to our database, and we have a script to anonymize everything and structure everything so that we can then work on that data. We have different roles, editor role that allow the user to segment, label the images, and also do measurements on them. We also have the viewer mode just to check that the data is properly done, but also the reviewer mode that allows specialized people to look over the editor work and just refine the measurements. And finally, my role, data scientist, where I export all the measurements done in this platform, and then we are able to analyze them. Apart from that, some of the measurements are also done on EchoPack, and through Orthang, we receive this DICOM structure report that we have automatized the pipeline to impute all the data in REDCap, which is a system that allows us to have all the clinical data for all these patients. And finally, from echocardiography data, we can also get strains. This data, on one hand, we receive the images and the strain patterns through Orthang, but we are also receiving the data export through REDCap. These tools and having all the raw data, and likely in other projects that we will just get all these reports, is that this allows us to go back and forward into the original images and try to understand better what we are looking at, and if there might be any error, just to modify them. On the other hand, we also have ECG data that we are acquiring here, and we are receiving these digital images through these digital EKGs through REDCap, and we have implemented a tool, an ECG viewer, that directly automatizes using AI, using IONET, automatize the segmentation of the ECGs, and we are segmenting QRS, we are segmenting T-wave and also P-wave. So this allows us to look faster at the measurements that we are doing here, and this tool also allows us not only to segment, but also to do measurements inside, not having to do them manually. Apart from that, for the clinical data pipeline, the traditional measurements, some of them we are receiving them through REDCap, and as I said, some of them are directly being imputed to REDCap using this DICOM structure report. But as you can imagine, looking at about 300 clinical variables for each of the patients is kind of difficult. So we have implemented the Transcode Explorer, that it's a tool that allows us to look at different types of clinical data. We have continuous variables, we have binary and categorical variables, but there are also temporal features, and we, in our group, use a lot of dimensionality reduction algorithms that I will be back here in a minute. So these tools allows us to, again, explore the data properly and go back and forth, and allows us to analyze everything from this tool. So going to the first objective, the second part was not only to look at the traditional measurements that Bart was presenting previously, but also to look at the ECG waveforms, strains waveforms, and also Doppler waveforms. So as we said before, this is our data set for this study. And going first to the analysis of the ECG, we were delineating these ECGs using the ECG viewer tool that I presented previously. And we were also implementing the tangent method correction in order, because this UNET, this AI algorithm, was trained with normal people. So since here we have some long QT, we needed to correct it. So we were using the tangent method, which is also automatized. And then we were doing a cycle selection, so we were only using a single cycle for patient. On the other hand, we did a systole and diastole registration, meaning that all systoles and all diastoles will be the same length, so that we can compare variability in between patients. Similar to this, for the strains, we were, again, delineating systole and diastole using the end systolic point that it's given in the reports. And we were forcing the systolic phase to have the same length as the ECG, so that we were also able to compare, not in between patients, but compare the ECGs and the strains. Finally, the Doppler delineation was done in the image analysis platform that I presented previously. And in that case, the waveform registration was based on the different physiological points that we can find in each of the waveforms. So first, going to the results of the ECG, we can see that there is a decrease R-peak in homozygous group, and that, as Bart presented previously, there might be some abnormalities for homozygous, but as you can see here, carriers have a decreased value of the T-wave. These are the mean waveforms for each of the groups, along with the standard deviation. Then, going for the strains, we need to do more work on that. By doing this visual inspection in these strain patterns, nothing can be clearly seen. But as we said previously, there is a tendency to a higher mechanical dispersion in the homozygous group. Although it's not significant, we can see that it's higher, the tendency in this group. Finally, for the Doppler velocities, it seems like there is a gradient from non-carriers, carriers, and then homozygous, having prolonged E waves in homozygous, but also larger A waves, suggesting here some diastolic dysfunction. And the same happens in the aortic valve, that the S wave is also prolonged. So then, let's go for the second objective, that is to do a machine learning phenomena mapping using clinical data, ECG data, and echocardiography data. So when it comes to unsupervised dimensionality reduction in the field, in the medical field, what we have is we have two different types of analysis. The first one, and the one that we are doing, is the population analysis. Here, what we do is to take the whole patients, all the patients, and try to get all the features that we want to analyze. And from here, we try to project these patients in an output space where the patients that are more similar in the features will be closer. This allows us then to do to have a simplified representation of how these phenogroups look like, and do clustering and get probably a risk assessment for each of the populations, and ultimately get a treatment planning. Apart from that, we can also do individual analysis. In that case, what we would do is, now that we have the output space, we get the same features that we were using for training, and then we project the new patient in the already trained output space. With that, we can know in which phenogroup it's falling, and then try to do a treatment that allows the patient to move from a high-risk group to a low-risk group. So with that, there's a lot of clinical variables that we have been using. Just in big words, we have demographic information, including gender, BMI, birth weight, and symptomatology, or also diseases, history of disease. We also have ECG-derived information, traditional measurements, such as heart rate, QRS interval, QTC, and echo-derived information, including not only size of the left ventricle, but also Doppler extracted measurements. Apart from that, we also had ECG strange and Doppler, but in our analysis, we were only using the Doppler data. So for that analysis and the patients that we had a complete data set for all of them, were adding up to 46 participants. 9 of them were non-carriers, 22 were carriers, and 15 were homozygous. So here we are close to the expected genotype ratio. And this is the output space that we got. We can see by first glance that here there is a region where non-carriers are together, and here there is a region where homozygous are together, but we have another region where everything is quite mixed up. So what we did was to use a K-means clustering using the first 4 dimension, and for the selection of the number of clusters, we were using silhouette method. With that, we got 4 clusters, where each of them were containing different percentage of genotype population, but also we saw that their characteristics are different. So let's go and see them. First of all, cluster 1 is predominantly non-carriers, but there are some carriers. Then cluster 2 is mainly formed by carriers patients. Cluster 3 is a mix of carriers and homozygous. And finally, cluster 4, it's only homozygous. What we found is that cluster 1 and cluster 2 have lower BMI z-scores than compared higher BMI, than compared with cluster 3 and cluster 4. And this might be an indication of the impaired weight gain that we can find in propionic acidemia population. Apart from that, we also see some changes in the electrical findings. So cluster 1 and cluster 2 have low QTC when they are compared to cluster 3 and cluster 4. And apart from that, in cluster 4, we have some T-waves abnormalities. But when we look at the echo data, we find that left atrium is smaller in cluster 1, while it has normal values for cluster 2 and cluster 3, while cluster 4 has also a large left atrium, which is also a remodeling find in patients found in patients with dilated cardiomyopathy. But not only that, we also have a small left ventricle in these 2 clusters and large left ventricle in the other 2. Going into a conclusion of these phenogroups that we have found, it's like, okay, carriers were normally treated as a healthy population, but it seems that although some of them might be, there are others that are clustered together with homozygous, suggesting that they might be more affected than we were expecting, as Bart also presented with the traditional measurements analysis. So finally, going to the waveforms, again, here I am presenting the mean and the standard deviation for the ECG, but now for each of the clusters that we found. And similar to what I presented before, cluster 1 and cluster 2 seem to have similar characteristics to healthy patients or non-carriers, while cluster 4 is the one that has these lower R peaks and some T-wave abnormalities. For the strains, as we haven't found any big difference for the genotype population, we cannot extract big conclusions from here, so more work needs to be done in that way. But for the Doppler velocity, we do, and what we see is that cluster 1 has cluster 1 and cluster 2 and cluster 4 has almost normal S-wave, but cluster 3 has a reduced S-wave, suggesting this impairment in the left ventricle function. And this is also found in the mitral valve, where these flows appear later, having a higher isovolumic relaxation time. And again, a good marker for the left ventricle function. So with that, traditional measurements have shown that there are differences between groups and that heterozygous patients, carrier patients, might be more affected than we were expecting before doing this project. And on the other hand, machine learning phenomapping has allowed us to provide a valuable output space where clusters were displaying different characteristics, and in fact, these mixed clusters that we are finding seems that they are sharing PA-related cardiac structures. So, of course, this work shows promising results, but we still need to do more work with that data. So we need to work on with a more balanced data set for genotype mainly, but also always it's better more data to have more data, so not only balanced but larger. Then also it will be interesting to do some longitudinal analysis, so to check the changes that these patients can have over time and also relate this with the medications that are being used. Apart from that, more works need to be done in this waveform analysis, especially in the strain patterns. And finally, the results presented were only for pediatric population, but it needs to be done with the whole population to understand how these patients change over time. So thanks for your attention, and that's all.
Maybe a small comment to start with. So Carla showed this platform that we're using. So all the PA patients and the family members that are being scanned in Dr. Chowdhury's lab, they end up in the system in order to keep on enhancing this, increasing the population. But this is also open for other collaborators. So if anybody is interested in putting their data in there or just using this, because we can create separate spaces that only you see your analysis and this kind of things. So we're happy to collaborate there. And also one of the next steps, so this is a platform that we're creating for more general. So for example, also we work with another plain population of connective tissue disease where we also use this type of analysis. We do this also for cardiomyopathies and for fetal medicine in Barcelona, for example. And the idea is also to create a more personalized platform where you can follow up an individual over time. So the idea is that you can upload echoes, upload ECGs, upload measurements, and you see a time analysis of your patients in relation to other patients, and also in relation to, for example, what we learn with the machine learning. So we're working on this, we're starting to advance. We hope in the next couple of years to have this as a really clinical tool for the individual, or even for you at home to follow up if you want. So, but anybody that wants to collaborate, we're very open to this. Any questions about this?
That's super sophisticated, really intriguing. One of the things I was going to ask you about on cluster 3 versus 4, what I didn't hear at all was if it's a homogeneous population, what we know for certain in the clinic is diet effects, medicines, and metabolites are serious variables. Are you including those in your analysis? For example, amino acid levels, C3, 3-hydroxypropionate, 2-methylcitrate, free carnitine, liver function tests. Are you cystatin C, creatinine, urine levels of metabolites? Is this entering anywhere into the equations? Because your platform could be,
By now,
you could use this to further stratify. What's happening with that?
We don't run them in our office, those levels. Those are run by the metabolic person the patients follow. So we do get that data, but we haven't uploaded that. But that is something we would be doing to look at that. And I think we've talked about this before with other patients. So we are definitely looking at the change in the metabolic status and the change in the cardiac status and what's moving them from one cluster to the other, which I think is an important thing, what's moving them up and down between the clusters. And that's where that longitudinal data and the metabolic data would come in.
Even just recording protein intake in grams per kg per day, medical food use formulas, these are things that could determine
At this,
one person is in one cluster and one's in another.
Exactly. At this moment, we don't have that information available. So as we said, collaborations are fine. We, for example, are able to get this data very easily in the system. So we have different ways of doing it. As I said, for other projects, we are already including blood values. So the system is ready to do it. But we need access to the data or collaborators that are interested in order to do this. So, and also this type of machine learning cluster analysis, we can do on all data. So for different projects, we do it for different things. So that could be done also only on metabolites, for example, if anybody is interested.
But we are looking at adding that to this cluster. And we are also doing dietary history on the patients so that we know what they are doing. But that data wasn't ready for this analysis at this point. Yeah.
All the same mutations is really.
Yeah, they're all of the same mutations, so it's definitely very valuable.
And of course, you demonstrated the carrier also has the
Risk factor.
factor, cardiac, event. Cardiac manifestation, both in the echo and in the EKG, other things. So we know there's no line to draw between autosomal recessive and autosomal dominant. We see the MYBPC3, they are autosomal dominant, but also you see the carrier and homozygous, they all both have the manifestation. I guess the question here is, first question is if you go back to, we have so many carriers in this room, do we have data or survey to go back to the family history? Any parents or normal siblings, they also have cardiac events?
So that's what we are doing now, because initially we were focusing on the homozygous, and the carriers sort of didn't even come in for checkups or anything, right? But if anything, it is definitely a risk factor. So if they have hypertension, they have some other high cholesterol, they may be at greater risk for developing some kind of cardiac problems. So, and that may be in an older patient, may not be in a younger child, So we are looking at that in our population, and we are going to be getting their histories and their events. So we don't have that information, but at least we know it is a population we have to look at. We cannot just ignore the carriers.
The other thing we found is TTN, MYBPC3, and then DSP, they also affected those families.
Exactly. So we have patients who have MYBPC3 and homozygous for PCCB. We have patients who have DSP and homozygous for PCCB. So we are looking at that, So we do have, as I said earlier, we have the traditional cardiomyopathy in vitro panel that we have, which does identify a lot of these VUSs and identifies these genes. So they are being put into the matrix, but again, this analysis here isn't 100% complete, to be honest with you. This is all data that we have. This is just the first look around with that,
Thank you.